Good morning, everyone. This is Dr. Black. Welcome to our CME for this morning. Just give us a couple minutes as we arrange the screen sharing. And once that has started, we will get started with our meeting. And I see that our screen sharing has begun. So welcome to our first CME for 2021. So happy New Year to all of you. And thank you for your participation in 2020. And we look forward to your continued participation this year in 2021. So just to let you know, there will be some CMEs mixed in with BMC accredited CMEs, as some of our CMEs specifically cover issues that are relevant to Princess Margaret Hospital and what we call in-house meetings. So just look out for them, and they will be designated, so you will know which ones you need to apply for your CME credits for. We will let you know. And with this meeting, you will see a feedback link posted in the chat. Please do the feedback, as this helps us to answer your questions and make presentations specifically to your needs. So this morning, we have the pleasure of having the Princess Margaret Hospital lab present to us. And Miss Karen Ingram, who is the Deputy Lab Manager and Quality Control Manager with oversight for training and maintenance in the Department of Pathology and Laboratory Medicine, is going to run this morning's meeting. So I will hand the meeting over to her, and she will introduce to you the different speakers. The topic for this morning is really varied. It's a couple topics that the lab has chosen to address so as to improve specimen acceptability and lab functions for the care of our patients. So Ms. Karen Ingram is also accredited with status in the Jamaica Agency for Accreditation. And so it's my pleasure to introduce the Deputy Laboratory Manager at Princess Margaret Hospital, Ms. Karen Ingram. The floor is all yours, Ms. Ingram.
Thank you, Dr. Black. I'd definitely like to thank you for giving us an opportunity to share with the clinicians as we seek to improve our services and offer our best quality care and services to our patient clients. So what we are doing, like Dr. Black said, it's varied, but it's really all centered around specimen acceptability, because at the end of the day, whatever we bring into the lab determines the quality of the results we are able to give to our patients, our patient clients. So we're going to try to make this brief just in case there are a few questions at the end. So we're going to get started with our first presentation on specimen acceptability, and our supervisor for the central accessioning area, which is our phlebotomist, she will go ahead and conduct this presentation. So Jalna, you can go ahead, Ms. Jalna Bullard, our supervisor for the central accessioning area. Jalna, you can go ahead and get started. I will just have the presentation rolling.
Okay. All right, thank you, Ms. Ingram, and good morning to all the participants on this Zoom call. So I've already been introduced as a supervisor of central accessioning. This is about my 7th month here. So in order for you to really appreciate this presentation, it's important that you understand the path of workflow for the laboratory. Please let me know if you can hear me.
Yes, we can. Go ahead.
Okay. Alrighty. Thanks. All right. So in order for you to appreciate it, you need to have some understanding of the path of workflow of the laboratory. So so the laboratory is divided into workflow into 3 processes. We have our pre-examination, our examination, and our post-examination. The central accessioning unit, we manage the pre-examination process of the laboratory. So this includes the examination, ordering, or as you would say, a requisition. You as physicians, when you do your requisitions, sample collection, sample transport, sample receipt, and processing. So in the central sessioning area, we're not only considered the face of the laboratory, but we are also the gatekeepers. And since you are an integral part of this process by way of requisitioning samples, by way of sample collection, by way of transporting those samples here into the laboratory, you're also considered gatekeepers as clinicians and physicians. And so we consider specimen acceptability to be a concern and the business of all involved in the pre-examination process of the laboratory, and hence our presentation today about specimen acceptability. So basically the purpose of this presentation is to define the process that we use when a specimen submitted to the lab doesn't meet the established requirement. And we believe that standardization is necessary to provide quality in the laboratory results. And we are guided by JANIC, which is an accrediting body that we have gained our accreditation from. We are a laboratory that follow those standards. So in many cases, we have, well, in this particular case, we have chosen specimen rejection as a quality indicator, something that we monitor every month, and we collect statistics on this particular indicator so that we can see where we need to improve and to see where we can do better on this particular indicator. I'm going to start with some of the common causes of specimen rejection. The first, hemolysis, icteric samples. We have quantity not sufficient, clotted samples. Samples are coming down in the wrong tube, mislabeled samples, and specimens that are too old to process. Next slide. Okay, so from our statistics, we find that the majority of our specimen rejected samples are hemolyzed samples. We get about 50% of those samples that come down that are in our specimen rejection category are hemolyzed. Here, the slide demonstrates the different grades of hemolysis. The first tube on the left is more hemolyzed and grossly hemolyzed, and the other is hemolyzed slightly. Next slide. Hemolysis affects tests, and these are the types of tests that are affected by hemolysis. You can have an increased potassium, or LDH, AST, ALT, CK, iron, TP, phosphate, albumin, magnesium, calcium, and ALP. They will all give falsely elevated results for these analytes. On the other hand, hemolysis decreases results, can give false results for troponin T, haptoglobin, the bilirubin, amylase, and the bicarbonate. Common causes, this is a common cause of hemolysis. I know that most physicians and clinicians, they prefer a syringe to draw blood. And so in that case, the syringe has to be stuck into the cap of the tube. And in many cases, sometimes when you push down on the syringe, the blood as it comes out of into the tube, sometimes the pressure is too much and it lyses the cells. So we just asking you to be careful if you use this particular tool or method. You must be aware not to press down too hard to cause hemolysis, but it is a common cause, as well as the gauge of the needle that you would use. Another common specimen reject that we have in the laboratory is clotted samples. Mainly this is due as a result of insufficient mixing of the additive that is in the tube. And so therefore you would get the clots that is demonstrated in the slide. We see these in our ABGs, and therefore the sample is then rejected. CBC samples as well as the PT samples or PTT samples. What we recommend with the CBC and coagulation is that you invert the tube gently 4 to 8 times, because if you invert it too often or too hard, it will cause hemolysis as well. Okay. Next slide. So with the coagulation tube, we know that there is an additive in the tube, and we would like to maintain a 1:9 ratio of blood to that additive. On the tube, there is a mark on the tube, a black mark, looks like an arrow, that indicates where the blood should stop once during the collection. Now, if you're using a vacuum cleaner or a method like that, most of the time, that system allows the blood to stop on its own at that point. If you're using a syringe, again, you have to be very careful and mindful that a 1:9 ratio is important, and to make sure that the blood is at that level. Otherwise, the sample will be rejected. There are several examples. The first being an overfill. The end is QNS, and the middle one is actually the correct amount that we would allow or that is acceptable to the laboratory. Next. Lipemic samples, we see those not as often, but again, the tube on the left is a lipemic sample, and that will be rejected, cannot be used in the laboratory. And on the right, you see a normal sample, which is acceptable for processing in the lab. Next slide. So these are some of the tests that are affected by lipemia. The bile acid, the direct bili, the TIBC, and the magnesium are all increased if we actually run a sample that is lipemic. And you would see a decrease in your sodium, potassium, chloride, these are your electrolytes, your bicarbonate, and your LDH. So when we call or we say that we have lipemia or hemolysis or so forth, we are doing this because we are practicing patient safety and we're asking you to redraw. Sometimes we know that it is a pain, but we're asking you to just follow those protocols for us, please. Another thing that we do see in the lab is with a CBC sample or the purple top, which also requires for the tube to be filled at a particular level. There's a mark on that tube as well. The first tube shows an overfilled tube that is filled all the way to the top. The middle is QNS, we are unable to process, and the last tube or the last slide shows the ideal. If you can see where the top of the blood is just at the mark, the black mark on the tube. Next slide, please. So this is an ABG that's placed in a specimen bag with ice. I think that is placed, we don't want it in directly on the ice, but it must be cooled. So we want you to be careful about putting it directly in the bag with the ice, as well as we want you not to have any needles on the tube for the ABG. We'd like for you to at least check for specimens for the clots before they're sent down. So and we normally do that as well when we, prior to actually putting it in the instrument, because it causes a lot of problems with the instrument. going down and not being able to be used when a clot is put in the system. We also reject samples that have air. And so we would like for you to be mindful that when you send an ABG, that it does not have any air, as it increases the partial O2 for that patient. This has to be signed and read.
This was in the box and looked like anything.
Yeah.
I was caught in the box and I saw it.
Yeah,
Okay.
put it back on there. Can I have the next slide, please? Close the door.
Miss Ingram, can you advance to the next slide for her, please?
Hello. Good stuff.
So what to do is keep talking, Miss Bullard, while we wait
Yes.
for
Okay.
advance the slide. I'm not too sure
Okay.
if having some
Yeah.
issue.
What I will say at this point too is I just want to introduce you to the operations times and of the phlebotomists when we go to the ward. We know that phlebotomists go to the ward between 7:30 and 8 o'clock in the mornings. The protocol there is that in most cases, we have a chart where clinicians would place their request on those charts, and the phlebotomist would follow that chart in terms of determining which patient to have blood draws. There are some instances where those requests may not be on the chart. So if you're not able to get it on the chart, we do have a second round where the phlebotomists come up about 12:30 in the afternoon, and they would do a second draw, or they do a second round. So if you have the case where the morning you were not able to get a patient's blood drawn and you missed the phlebotomist, and they can do it on the second round. Okay, I see we're back. Oh, no, we're not. Let's see.
Yes, your slide has changed. Go ahead.
Okay, yeah, I'm noticing, yeah. No, because I went to my,
It's okay. Go
sorry,
ahead.
I lost.
It's okay. Go ahead.
I lost my Zoom thingy. Okay, here it is. Okay, so sometimes what we also see, just going back to the slide now, is when ABGs come down, the blood is contaminated. The water or the ice that's in the ABG, and so we reject this type of sample as well. So we're just asking that you are aware of sometimes that this happens. We know that ABGs are very sensitive and samples. So we're asking you to also just be aware that these things are happening and how to prevent them. Okay, so this slide here is just basically giving a demonstration of where to put the labels once you have them printed. So we're asking you to place the label on the side of the original, the front side that we would call it, of the tube. So that would be the side where you would have written all of your patients' demographics and so forth. We'd like for you to place the label over that particular side and not the side where we can see the sample clearly. If you block that side, it's a little difficult for us to tell hemolysis, the different things that we're looking for. These are blood culture bottles. Again, we're asking you to place the labels on blood culture bottles. If you would notice, the one to the left, we'd like for you to place it on the, not on the label, the original label of the blood culture tube, but just on the side of it and up and lining up right. Okay. If you would see the second one, it's more horizontal. So we are discouraging that practice. And it's covering the label of the original bottle. Okay, so we would like for you to practice the placing of labeling on the blood culture that's on the left of the screen. Next. Okay, Q&S samples for red tubes. If you would notice, the slide on the left, or the picture on the left of the slide, is an ideal amount of blood that we would require. It's right at the bottom of the label. If you need a marker to guide you, it's right at the bottom of the label. For red top tube, that is sufficient. And on the left, on the right, sorry, that particular specimen is considered Q&S. We would not be able to even do a CAM7 on that. Okay, next. End of slideshow, sorry. All right, thank you very much for listening and your participation, and we look forward to you continuing to be gatekeepers for us as well in terms of specimen acceptability.
Okay, thank you so much. I see Dr. Sinqui has her hand up. Dr. Sinqui, we're going to unmute you so that you can ask your question. Dr. Sinqui, are you still with us? Okay, so we can move on to the next presentation.
Okay, good morning again. The next presentation will be by our clinical chemistry supervisor, Dr. Marjorie Palmer Newball. And I just want to remind our laboratory supervisors to please try to stick to the time because we want everyone to have an opportunity to present, and this is only a 1-hour session. So Dr. Newball, you can proceed.
Thank you, Mrs. Ingram. Good morning, everyone. Are you all hearing me?
Yes, we can hear you.
Okay, awesome. Okay, in the interest of time, we'll just go to the next slide, please. So as the chemistry supervisor, we are more involved in the analytical and the post-analytic assessment of samples that comes into the laboratory. Chemistry has undergone quite a few transitions within the last year or two. And one of the transitions that we actually recently experiences the update of discontinued or changing the test somewhat. For example, two tests that I want to highlight is the Chem25. The Chem25 is no longer available as a panel, actually. The tests are available, but not as a Chem25 panel. We also have altered the renal panel to exclude magnesium. So while all test assays are available within the chemistry department, we no longer offer these two tests as panels. That includes, for instance, the Chem25 no longer exists, and the renal panel does not include magnesium anymore. And this is in part because of the cost. And as I've given 2-3 examples here, the first one is your amylase. An amylase test kit that has 1,050 tests cost over $1,300. So when we look at the cost, we had to make a few changes because we did not want the patient to incur these expenses. So we somewhat alter the profile of some of the tests now being offered in chemistry. Next slide, please. So here we have another test that has been discontinued, and this is only temporary. So as of February 9, 2021, we are no longer offering the CSF protein or the urine protein. And as I said, this is temporary. So once the tests have been validated, we will resume offering these tests. As I said, one of the reasons why we don't offer it as it is now is because we have not gotten the CSF protein and the urine protein validated. So once we get a clear with the COVID situation where individuals from the states are able to travel, they'll be able to come into the department, into the chemistry department, and have these two test sample types validated. Next slide, please. Next slide. Okay, so what I want to highlight here is stock out. In the department, when we talk about stock out, we're talking about not being able to offer a particular test. Stock out may happen for several reasons, whether it's credit hole or something else. But nonetheless, the bottom line is that we're not able to offer a particular test for a particular period of time. And so when the test is ordered by the clinician, for example, troponin, which is a critical test, if you order the troponin and we have a stock out situation of the troponin, we'll do one of two things. We will credit the test and as indicated as test not available, abbreviated TNAT, or we will outsource the test. When it comes to outsourcing, we outsource only tests that are critical, such as the troponin and your electrolytes. For other tests that are not considered critical to patient care, what we'll do temporarily is to indicate that the test is not available. And as a part of our protocol, we would also indicate to the clinician through the head of sections, give an idea when the test will become available. Now, it is imperative that we are all cognizant of the protocol of the laboratory when it comes to stock out of critical tests like the troponin. What we have indicated, what we have been doing is that we would, as a supervisor, take the initiative through the management system, indicate the test is not available. However, if the test is a critical test, that we would outsource the test. We outsource using organizations like Doctors Hospital, as you see here. What we strongly endorse is you order the test only if it is critical to the patient at the point in time. And next slide, please. What I've indicated is do not just order the test that is out of stock, that is unavailable. We ask that you call the department and you speak with the technologist who's on the shift and indicate that you do need that test to be outsourced because of the clinical presentation of the patient. We have an example here where during the period of February 18th to 25, 2021, we were out of troponin. And as a critical test, we have taken the initiative to outsource only those that the clinician had called to indicate were very important to patient care. So some of the tests, even though we saw a marginal decrease in the order of troponin, regardless of us indicating to the clinicians that only order the test if it is very important to the patient care, we saw a marginal decrease in the order. Nonetheless, we proceeded to credit those troponin tests that were ordered. And if the clinician called to say that this is an important test, we would like to be outsourced because we need it for the patient diagnosis, then we would proceed to outsource it to doctor's hospital, which is what we did during this period shown here. We eventually outsourced 35 troponin tests, which cost, as you can see, nearly $4,000 for those 35 tests, because each test at doctor's cost, each of the troponin tests costs $106 plus. Whereas at PMH, this would be significantly different. That is significantly less in cost. That is why it's important that you order the test that you know is important to the patient or is critical to the patient care. What was striking for us is that of the 35 troponin tests that were outsourced to doctor's hospital, only one was slightly elevated. Our normal range for troponin is 0.000 to 0.0450. That is our normal range. So of the 35 tests that were outsourced, one came back with a slight elevation, which was 0.0890. So when clinician calls and say, my patient is having an MI or suspected an MI, and we would like this troponin to be outsourced, we took the initiative and we sent within that period of February 18 to 25, we outsourced the 35 and only one came back with a slight elevation. Right, so that is why I implore and I beseech and I ask the clinician to be sure that this test is really needed when it comes to outsourcing, because of the cost that is associated. And I know we are saying that when it comes to patient care, we should not consider cost, but somebody has to pay for it. And quite a few times we're cognizant that it's not necessarily the patient. So I'm re-emphasizing that whenever it comes to stock out, please order the test if you know that it's very important to the patient care. Okay, next slide, please. As of last year, I think we had a merger of the chemistry and serology department. And it's a partial merger because not all serological tests are done in chemistry. And this merger is a result of the new instrument that we have in chemistry, which is from Siemens, and it's called the Atelica solution. Now, this analyzer is able to do a lot of tests, not exclusive to chemistry and serology, but it can also do blood bank and microbiology. But for us, we restricted to serological and chemistry tests. And the benefit of it is that in addition to the merger of the two departments, the Atelica solution is able to provide, especially for the serological tests, you're able to get most of, if not all of these tests that are done on the Atelica in a shorter turnaround time. So that is beneficial to the clinicians. So we have tests like PSA and thyroid that would usually take about 72 hours. You're now getting those results in minutes. So, and these tests are also now available 24/7. So that's one of the one of the changes now that we have undergone in the chemistry department with merge of the serology department. Next slide, please. So this issue here, we're talking about the critical results called out in the clinical chemistry department. What happened is that last year we did an assessment between the period of January 1st to October 22nd, 2020. And we did what is called a critical call out, which means that we are calling the clinicians, or we're calling the ward to indicate that we have a critical result for the patient, for a particular patient. We have been having challenges with this process. Reason being, when we did the assessment, we had roughly a total of 1,500 thereabout tests that were called out within that period of time. And of that 1,500 plus call out, most of them, we had like 48 point, nearly 50% of them were unsuccessful call out. That was because they were unsuccessful because the clinician could not be reached. The patient was not on that ward anymore, or the patient could not be located. Nobody knows where the patient is or anything. So we were not able to disseminate the result, the critical result of the patient, and that has been problematic. And we're seeing that this is a big problem especially in A&E, where of the 48.9% of unsuccessful call out, we're seeing nearly 80% of that coming from the accident and emergency department. And so this is a big problem because it means that patient care is jeopardized because critical result is not presented to the clinician, which should help in the patient care. So this is something that I just don't want to just present it here. This is something that we actually need to try to find means and ways to improve whenever we have a critical results, because I think the laboratory is doing their part by calling the result out, but not being able to reach whether it's the nurse or the physician, but not being able to disseminate the information to the clinician so that patient management can be improved or can be expedited. So that is a big problem we're experiencing in the chemistry department, and we would like that to be investigated possibly and find a better way to improve this service between the laboratory and the wards, in particular the accident and emergency department. And I think that is it for my slide, my presentation. Thank you so much for your time.
Thank you very much for that presentation. Before we move on to the next presentation, and you can start loading the oncoming slides, Ms. Ingram, but I have a question about peritoneal fluid albumin. How easy is that to order in-house, and how do you order it and see the results? Are you able to speak to that?
Hi, Dr. Black. As it relates to peritoneal fluid albumin, that is something that we would have to consider now. But as I indicated, that when it comes to any type of specimen that is done in chemistry that is outside of your serum and your whole blood, we have to revisit that. That is something that we recently encountered, that we have to get that validated. So if you do have that, if you have that test that you want to become an option available in the chemistry department, then it is possible, but there's a process that we have to go through, and in order to make that realistic. So as I said, it is possible, we just have to go through the process of implementing or providing that service. So further discussion is necessary.
So is it that the physician has to make a request for you to implement it, or saying it in this forum is good enough?
No, you can make a request, and that would go through the management, to the supervisor, and we'll have a discussion. And of course, it has to be advertised, because I think one of the things that one of the reasons why we select to offer certain tests is that we also have to look at the volume of requests. If we just have occasional requests, then I don't know how much profitable it would be in terms of cost. We still have to factor the cost. So if it is advertised that we now offer that, once we go through the different protocol and we decide we will be offering it, then we have to make sure that there is frequent order for us to provide that service. And that is pretty much the test.
Understood. Thank you. And yes, we will try and help look into the critical results, 72% of them coming out of the emergency room department. What we need to bear in mind in this situation, however, is a lot of labels are printed through ER that actually come from the rest of the hospital. So that 72% number ER is not really ER. So yes, agreed, we need to find a way to work through that.
Yes, Dr. Black, and I really don't want to consume too much of the time, but that is something that was presented to the laboratories department in terms of the rationale why we see so many of the requests coming from A&E when they're actually not A&E patients. But one of the protocols that we have implemented in the lab, and maybe it is something that you guys can also adapt, is that once you log into the system using your code, and when you're through, you log out of the system. That way, anyone who chooses to use the LIS or whatever, the ICE, that person would have to log in with his or her code. And that way you will see, and they should do so from their department, whether it's male medical, male surgical, wherever. They need to use their system there and make the request there. And so it will show a true reflection that this patient or this order is coming from that department and not the accident and emergency department.
Okay, understood. Thank you. And I
Yeah.
will make sure we disseminate that information.
Yes,
Okay,
Dr. Black, also, I'm not sure that would really work as long as they're using A&E's printer, it will come out as A&E. But what they can do is write on the label the actual ward where the patient is located. If they can write that on the label, that would be helpful until we're able to address the label printer issues that we have. We know that the wards need extra label printers, and that's one of the reasons why we're faced with this situation. So they can just write the name of the ward on that label and just put a line through the A&E, that would be helpful.
Agreed. Understood. Will do.
So
Thank
we'll move now to serology. This is just a few slides. Our serology area is being manned by our acting supervisor, April Cartwright. April, are you there and ready?
Okay.
I think we have a hand raised by Dr. Parkinson. Can we take that question first?
I just wanted to say that a lot of patients are kept in emergency room for extended period of time, and so a lot of the labs that are in emergency room are patients that don't have a bed to go to or don't have a ward to go to. So that may account for your increased load also.
Okay, thanks, Dr. Parkinson. But I think what the problem was that we had experienced was that the patients were actually not in A&E when the critical results were called to A&E, and there was no one who knew which ward the patient was located on. And that is part of the problem with the wards not having label printers and the physicians having to print their labels in A&E. So the labels will come out saying that the patient is A&E, is in A&E, when actually that patient is on the ward. Okay, so we'll move over to serology. April, are you there? If April is not there, then we'll move on to our transfusion medicine. Mario Williams, who's our supervisor for transfusion medicine.
Hello, good morning.
Good morning.
Can you hear me? Oh,
Yes,
okay.
I can hear you. Go ahead.
I will be just covering the transfusion report form. The transfusion report form, because this is one of our quality indicators for us keeping track of our products, blood products, the FFP, platelet, and the packed red cells. Occasionally cryoprecipitate. The form that we have, the transfusion report form accompanies each product that leaves the laboratory. It is also supposed to be returned with the express bag, the empty bag, having the relevant information with regards to the patient's vitals prior, before and after the transfusion. Now, this form is broken up into several compartments. I can't see it really on this screen, but I'll just describe it. The form is broken up into several compartments, and I have labeled them A through G. Patient data and blood component data are inputs that would is information that would be input into our computer from the requisition forms. If you want your forms coming back labeled so that you understand that you have the correct patient, then you must give us patient's name, date of birth, sex, ward, and even if you, with the diagnosis, you put that in there, we can add that in. That is all printed back on the form at the very top. You'd have the patient data, and then that would be section A. Section B would be the blood component data. Whatever we do with the unit in terms of the unit number, the expiration of the unit, who did the compatibility test, whether the unit was compatible or incompatible or least incompatible, because sometimes we send a least incompatible where the physician would sign an additional form to say that we acknowledge that this is least incompatible and we're still willing to use it to assist the patient. Okay, it would tell you who performed the compatibility testing, date and time, give you the volume of the unit you're getting, and which blood component. So it names the blood component on the form, FFP, platelet, RBC. And section C, so that you know that you're getting the unit that we actually say that you're getting. The person who collects the blood, which is the blood component delivery section, would sign the form along with the text and go through at least 3 or 4 statements that say this is the correct unit, and noting that patient's name, ID, the blood group on the unit has been is the same that that we are giving out, and we sign date and time that the unit leaves the department, so that we know we're actually sending out exactly what we would have cross-matched. The double check is done, that's section D. Double check is done by the 2 persons who would be attending the patient, the transfusionist, one, and then a co-identifier with that transfusionist to identify again the unit, to know that you would have gotten the right unit. You're going to check the unit number for identification, check the identification of the recipient because the name is on the unit along with the ID number. You check the appearance of the unit to make sure that what we gave you was satisfactory and doesn't have any clots or is hemolyzed as best you can in trying and before issuing to the unit. So your double checks would tell you that this patient who is O positive has an O positive unit here. It's labeled, it has the name, it has the number, and everything is okay as far as we're concerned in terms of the exact unit that was cross-matched to the patient is going to the patient. Okay, and then once you sign off on that, it becomes important for you to check the vitals of the patient before issuing the blood, as you would get the process ready for transfusion into the patient. We would like for the name to be written, an understandable name. Signatures, sure, you can put your signature on the paper because it's actually your signature, but go on to read your name because it becomes important when we get that form back. We want to see the name of the person who started the transfusion and the information that we would put into our system that comes back before the transfusion started would be the blood pressure, the time, date and time that the unit was transfused, the temperature of the patient at the time, and pulse rate of the patient at that time. So this vital information should be logged prior to the transfusion of the unit, and then After the transfusion is completed, whoever it is that completes the transfusion, which may not necessarily, and as we would sometimes see, it's not always the person who started the transfusion, but that person's name and signature must be on the form also, along with the same information, the corresponding information that would be gathered at the end of the transfusion, blood pressure, pulse rate, temperature, date and time that the unit was transfused. Okay. If for any reason during the course of, prior to, or after the transfusion, there's a reaction in the patient, there's a section below that that says incidents, and it gives the symptoms of the incidents here, the whatever incident that took place, and this is before, during, or after. We would like for it to be listed on this form. When that information is placed there, if it is before, we know that it is probably not a transfusion reaction, and we ask that if an incident occurs before, even before you put the bag, if say the hair plug goes down or something like that, that you would normally use, then we would like for you to try to get the unit back to us and not hold it on the ward with the patient where it's not properly placed in a authorized refrigerator. So we can hold, if you get that back to us before entering the bag, then we can re-reserve that unit for the patient, hold it for you until that is taken care of, and then we can reissue the unit to you so that you can go ahead with the transfusion. Now, anything that happens during the transfusion, if you, for any reason, have to stop the transfusion, and it is not affecting the patient in such a way that it's probably causing a hemolytic reaction of that nature or anything like that, it might just be a problem with the hair plug or something else that needs to pause the transfusion. Sure, you can stop the transfusion temporarily, pause it, and once you would have assessed the patient and gathered what's wrong and fixed those problems, then you can continue with the transfer. But if you disconnect that unit and you send that unit back to the laboratory, you will not be getting that unit back. And if we're low at that time with blood, we may not be able to reciprocate and give you another unit almost immediately for the patient if they're going to be needing it. So we ask you to look at the problems you may be having, because sometimes as soon as they say the patient might give you something or you check something, persons tend to disconnect the bag right away, take it out, send it down to the lab, hope that we send that same bag back. No, that won't happen. Once the bag is disconnected, once it comes back into the laboratory, then it has to be discarded. Okay? If there is transfusion reaction that occurs during or after, then there are some other things that we would get into. Once you would have checked whatever the incidence is, send it down to the lab. We ask that you pack whatever the remaining blood in that by RBCs, platelet, FFP, whatever the remaining product is, to shut it off, put it into a biohazard bag, fill out the form appropriately, take that form and put it in the compartment next to the unit, not in the same side as the unit. Put it in the same side as you close that off, that turns upside down, the blood or whatever drains, so messes up the form, we can't see anything, we can't use it. Then we have to be trying to get ward back, which is sometimes very difficult, unless sometimes you actually make a trip up there yourself and say, where's the other form for this? Can I get a copy of it or whatever? But once the transfusion is completed, the empty bag comes back, biohazard bag with the form filled out, pre-transfusion vitals, post-transfusion vitals, anything that would relate to an incident, all of that should be filled out and then sent back down. Now, we ask that if you're expecting a transfusion reaction, a post-transfusion sample be taken off and sent along with the bag. And the lab must be notified, blood bank transfusion area must be notified that this is a suspected transfusion reaction. We're sending it back and we're sending a post-transfusion sample with it, so that it moves then on to another form where we would have to do a transfusion workup, transfusion reaction workup. Okay, and when the form gets back to us, we would sign receipt of getting that form, date and time, and then be able to proceed further in the event there's a transfusion incident. If there's no incident, the information from the form is logged into our system, eDelphin system, and it completes the transfusion for the patient and it finishes the transfusion. Any information that's left out that we don't get leaves the transfusion open. It leaves it unfinished. The problems I see that we may get is normally in A&E or in theater, where things, I guess, get a little bit hectic and stuff, and certain things might be missing. Now, sometimes in the process of transfusion, or you might lose a patient and stuff like that. We would like in that fashion. So the transfusion reaction form, I see workup form, I see that came up on the screen. But what we do with that, we check the clericals, make sure there was no clerical error first, with regards to the issuing of that unit, and then we will go back and through each of the pre-transfusion sampling and post-transfusion sampling and work those up side by side to determine whether or not a transfusion reaction has taken place. So thank you very much. Hello.
Thank you, Mario. I think there was one question in the chat.
Yes, with regards to blood transfusion, is there a plan for it disappeared. I am very sorry. Yes, with regards to blood transfusion, is there a plan for a presentation on MTP, as we are having an increasing trend on inner city violence, casualties, MASH casualties and incidents? I don't believe we have a protocol established for this.
No, we don't have a protocol established for that, and right now we're sort of lacking a blood transfusion committee that would assist us in these things, such as mass casualties and stuff like that, to be prepared for things of that nature. Okay. So that is one of the drawbacks that we have. The blood transfusion committee not being in place to help us to sort of have some of these plans put together and in place as we should ought to.
Okay. Thank you.
Thank you too.
And so, Dr. Bassett, you had asked a question about getting individuals access to ICE. So, Mr. Frank Reed at extension 7853 can be contacted for anyone needing codes to access ICE.
Yes, Mr. Reed will direct them to where they need to go and the forms that they will need to fill out in order to get access.
Yeah, could I add that IT seem to want the process to go through them. So usually it's best you send a list to IT, and then they would go from there.
Okay, so our last presentation will be conducted by the supervisor of microbiology, Mr. Allison Scavala. And we ask also, Mrs. Scavala, that you keep it within the time frame that was allotted.
Hello, can you hear me?
Yes, we can. Go ahead.
Okay. I'll do my best to try and keep this within.
It's a bit low. You need to speak up or bring the mic up.
I will do my best to try and keep it within the time limit, but it's a lot to get in, so I'll just concentrate on the things that you need to know, and hopefully it will help you get through microbiology. Of course, you know that there are systems that you need to learn how to operate for microbiology. ICE and SunQuest are the two key systems. The samples that we get in microbiology are things for cultures like blood cultures, stool cultures. We're the area that does the SARS-CoV testing. We do urines, respiratories, the chlamydia and GC, the fungal cultures, and all the other miscellaneous cultures. Things to remember when collecting your sample. Ensure that you have the correct name on the sample. If you have no name or the wrong name, it will be rejected. We would like to know the ward, and hopefully the doctor's name or the doctor assigned to the patient is at least on the system so that we can notify you if there's any positives. Medical record number is absolutely necessary. There's no way of getting around that. The tests must be specific because certain tests will have different applications. For example, urine. You can have about 5 different things for urine. So if you just send down a urine with not indicating that you need a pregnancy test, you might miss not getting it because we did not get the information to test for it. So please indicate all the tests required for the patient. Specimen type not indicated. You send us a swab, but you did not say whether it was an HVS or wound swab. We would not know how to set it up. Wrong specimen sent. You want a throat swab, but you send a sputum sample. And we see that often where the doctor would request a respiratory, at least they want a respiratory test. They send a tracheal aspirate, but they order up a throat swab culture. And of course, too old to process. Usually the surgical areas have this issue. They would do their samples and they would leave the sample or do not bring it down immediately. So the sample was collected on Sunday. 2 weeks later, we got the sample for testing. That's unacceptable. Of course, expired bottles, expired stuff. We've seen expired swabs, and we've seen blood culture bottles in the past that were expired. We do not accept expired things. Things to remember: continued. When you do your blood cultures, aerobe and anaerobic bottle, by now you should know purple, aerobic, red, anaerobic. They are always done in pairs. Collection indicated, meaning that you need to let us know the collection time. Put the labels vertically on all samples if possible, because a lot of the samples have to be run on instrument, and if the instrument's reader is vertical, not horizontal. So if you put it horizontal, we're gonna have to reprint that label and put it back on the sample to get it to run in the instrument, and that takes time. Okay, the barcodes that are on the blood culture bottles is a big problem because the labels go over them, the machine cannot read them. And so when you print the patient's label, do not put it over the label on the blood culture bottles, because the instrument needs that label to assign that blood culture as aerobic or anaerobic. When you're doing your collection for your blood culture, ensure that you clean the top of the blood culture bottles. That will prevent any possible contamination, because we require sterile techniques for blood cultures. Time of collection is important. The instrument starts monitoring from time of collection, and we do rejection on time of collection. So pre-ordering labels and not collecting the sample on the day you did your label might be a problem. For example, if the doctor orders the test on the ICE system, prints the label for Sunday, but the sample was actually collected Thursday, that's going to be too old to process, because your time on your label and your sample type would indicate that you collected it too early, or you didn't turn it into the laboratory in time to be processed. So ensure that when you do your labels, that's the time you did your collection, or try to keep them close. Do not let them extend over long periods of time. Here are your two blood culture bottle types. You have them in adult and pediatrics. Also, these are examples of other stuff. Your respiratory containers, your stool containers. One thing that we've seen, and we try to discourage, remember that when you have sterile sites to collect from, do not use clean containers to put them in. For example, you cannot use a stool container to collect a urine. However, you can use a urine container to do the stool, because stool only needs clean, but urine needs sterile techniques. Okay? These are the chlamydia and GC aptamer containers, and they're not to be confused with the viral transport media for the COVID-19 and influenza. If you collect this tube and send it to us for chlamydia and GC, it will be rejected. Same thing if you use the chlamydia and GC aptamer tube to collect a viral transport sample for influenza or COVID-19, it will be rejected. So make sure you use the right tube for the right test. Okay. Any questions you may have, hold for the end, please. I hope I'm not going too fast. All your blood cultures are updated daily. Your blood cultures take 7 days to be completed. And if anything comes up positive, we do indicate it on the system. We do try to contact the physician. However, the ward location is often an issue. Okay, from gram stain to completion, you would have about 2 days because we have to do an ID and sense on all positive pure cultures. Mixed cultures are not given sensitivities. We just give you an idea of what is in the mixture. Please check on the LIS system first before contacting the laboratory, because often we have the results on the system, but the doctors come down and they would like results from our end. We discourage printing results and sending them out. It's not our policy. We prefer that you use the laboratory information system. Exceptions will be made when the system is down. Okay. Please remember that there's only 5 of us down here, and often it's only 2 persons in the day because we have to cover 24 hours. We do have assistance from other areas, but it gets real crowded, real hectic down here. We open 7 days a week, 24/7. We do a lot of tests, and so it can be very busy down here. Now, I've been asked to also speak on the SARS-CoV collection. Yes, we do issue the swabs from down here. We do encourage you to use the forms that are on the wards that have been provided for you to do the information for the patient. Also, we encourage you to, if you do not have the proper transport container, at least double bag your sample and make sure that the exterior bag is clean. You will have to sign in and out when you are picking up swabs and dropping off swabs. We encourage you to ensure that they are ordered in the system because we do not order. It's your responsibility to have the order in the system. If you don't have the order in the system, we will try and locate you, but your sample will not get run without you ordering it. At the moment, the Gen Expert doesn't have any reagents, so everything is being run on the Panther. We are doing 2 runs, one in the morning at 7 and the other at 8 at night. All results will be posted. Okay, one other thing, when you were doing your blood culture orders, please ensure that you indicate the request, indicate the blood site. If it's from a line, if it's from the arm, because that might be important in the way how we treat the results. With that, I would like to thank you for giving me this opportunity, and should you have any questions, I'm here to answer.
Thank you very much, Mr. Scavella. And while we await any questions that might be posted in the chat, I do have a couple questions that we did not get to answer that were posted in the chat. So one of them is when there are stock out situations displayed when attempting to order in ICE, is there a possibility to publish the reagent issues on the start page of ICE, or to email the providers, or some way to let providers know that there's a present stock out of the reagent and the test is not available?
Dr. Black, once there is a stock out, that information is sent to Dr. Burnett, and Dr. Burnett will email that out to all of the consultants, all of the physicians, I guess, on her list. She would email that out, but we realized that there is an issue with dissemination of information. So I'm not sure if maybe we can get a master list also to the lab that we can use, but we do email them out to Dr. Burnett, and she takes responsibility of disseminating that information to all of the physicians. Now, maybe Frank can answer to whether or not we can have that placed on the starter page of ICE, if Frank is still on the call.
Yes, you can hear me?
Yes, we can. Go ahead.
Yes, we can put it on the startup page. Once they give me the notice, it can go on the startup page.
Okay, so we'll implement that from this point forward, and we'll also ensure that it's placed on the startup page. I thought that was a very good suggestion, and yeah, we will definitely implement that.
Yes, that's a very good suggestion. Now, the other thing would be to make sure that it's taken down off the startup page once it becomes available.
Oh, okay, yeah, definitely. Once I'm notified.
Okay, and so we have another question here. Where can we find a printed or online list of all the tests done at the Princess Margaret Hospital lab?
The Princess Margaret Hospital, like I said earlier, we are accredited by JANAC, the Jamaican Agency, National Agency of Accreditation. We are accredited by the ISO 15189 2012 standard. And so all of the scope of our accreditation can be found on that website, JANAC. So if you can just put in JANAC or put in the Jamaican Agency for National Accreditation, look up Princess Margaret Hospital, the scope of all of our tests are there. Now, we also do send off tests that would not be listed there. And we have not, I don't think PHA has upgraded their website yet to the, we can put a list of every single test that we perform on the PHA website. That is something we can probably inquire about, whether we can have that availability to post our tests on PHA's website as well.
Hi, Karen and Dr. Black. Question for the clinician manual, would the test be in that? And is it something that we could consider if it's not there?
Yes, all of the tests will be in our clinician's manual, and we realize that we also are having issues as far as that clinician's manual being disseminated to everyone. So Dr. Black, if I could probably speak with you later on about having the manual posted on your maybe, I think you said you have the UWI.
We can talk offline on how we can disseminate that information and where it might be best to post it.
Okay, wonderful.
Neil Stephen has put the website. Thank you, because I was going to ask you to say the website again. So you've put the website in the chat, and I will try and find a list and see how we can post it to the PMH community and the local community. Do we have any other questions? So I do not see any other questions in the chat, and I think we have answered all the questions that were there. So Ms. Ingram, I would like to thank you and your team for putting on today's presentation and highlighting some of these issues for us so that we could work together towards providing better care in the future. So thank you very much to all of you and your team.
Thank you.
Dr.
Black.
Yes.
Dr. Black, is there a way that we can get a register list or attendance list of those persons who would have attended the session?
We can work offline. Yes, just send me a message and we will work on it offline.
Okay, thank you, and I appreciate this opportunity.
You're welcome. Thank you very much to all of you, all the presenters, and thank you very, very much to the participants. And so we've started back our CME sessions. Our schedule remains the same, the second Wednesday and the last Friday of every month. The next meeting will be on the last Friday of the month. And this meeting will be put on by Human Resources, and which is the 26th. And it will deal with all issues related to leave. So if you have any specific issues related to your leave, you can bring them to that meeting. And what I will do is try and get some of the information that you've asked for through Ms. Ingram's office, and we will find a way to post it to you. So thank you very much, and everyone have a good day.
Thank you. Same to you.